Hi everyone. I'm making another small video to help you guys quickly diagnose the endodontic cases in a clinical judgment exam. So, just like my other videos, this is not a tutorial and you need to be very thorough with the basic of all the endodontic conditions. But you can use this approach to help you save time in your exam. So, amongst the clinical cases, there will be 3 to 4 questions on endodontic diagnosis. And in each scenario, you have to make two diagnoses. One is a pulpal, and second is a periapical diagnosis. Now, please remember if there is no information given which is enough to support the diagnosis of either of these two, it is always in the best interest to leave it as a single diagnosis. And also, we'll talk about some conditions where, in spite of no information being provided, when is it safe to mark necrotic pulp as the pulpal diagnosis? So the approach is simple and straightforward. Always remember to refer to these things which are provided in the question. First, the chief complaint. Second, do they have any other information about the vitality test or the percussion test result, or have they provided any radiograph? After that, you go on making the diagnosis. Firstly, the pulpal diagnosis, and second, the periapical diagnosis. Now, in order to make pulpal diagnosis, these are the commonly seen options in the template: normal pulp, reversible pulpitis, irreversible pulpitis, necrotic pulp, previously treated pulp, or previously initiated therapy. The difference between previously treated pulp and previously initiated therapy is if the root canal treatment was completed earlier and the canal has been obturated, then it is safe to mark previously treated pulp. However, if the obturation was not completed earlier, then it is safe to mark previously initiated therapy. We'll talk about the remaining four options in the coming slide. Now we're going to make the diagnosis and we're looking at the symptoms, the pulp test results, if they are provided, and radiograph. Now, the radiograph are not very helpful in pulpal diagnosis, but yes, in certain situations where you have the irreversible pulpitis, which is asymptomatic, like in cases of internal resorption, they will give you the radiograph, and that is enough evidence that you have to select irreversible pulpitis. This is an important chart that you can refer to. The patient can have absolutely no symptom. In that case, there he can have three things: normal pulp, irreversible pulpitis, which is a type of asymptomatic irreversible pulpitis, or even a patient with a necrotic pulp can have no symptoms. So, how will we differentiate between these three? We will look at other information that is provided. Look at the pulp test results. Now, in cases of normal pulp, the response will be a small discomfort on exposure to hot or cold. However, in case of irreversible pulpitis, the response is there and it is often exaggerated. In necrotic pulp, there will be no response. The second complaint can be mild sensitivity to hot or cold, or can be sharp transient pain. Now, this is very straightforward and it is pointing towards the reversible pulpitis. Thirdly, there can be a presentation of prolonged or spontaneous pain. Now, this can happen in two situations: in irreversible pulpitis, which is symptomatic, and also in cases of necrotic pulp. The patient can be symptomatic. So, how to differentiate between the two? Well, there will be some information about the test results. If there is no response, it is safe to mark necrotic pulp. And if there is some response and the patient is having this particular complaint, then it is safe to mark irreversible pulpitis. Now, to make a periapical diagnosis, the following options are often present in the template: normal periapical tissues, symptomatic periapical periodontitis, asymptomatic periapical periodontitis, acute apical abscess, chronic apical abscess, and condensing osteitis. Please note that condensing osteitis is not a clinical finding, and there will be many questions on this, but in the radiograph section, not it is not a clinical diagnosis. So again, we look for the symptoms. This time we are going to look at tenderness on percussion test, and this time the radiographs are equally important. So this chart is again important for you to refer to. The patient can have some complaints and this can help you reach the diagnosis. If there is no symptom, what can be the condition of the periapex? It can be a normal periapex or it can be asymptomatic periapical periodontitis. How to differentiate between these two? With the help of X-ray. In cases of asymptomatic periapical periodontitis, the, the X-ray will show periapical radiolucency. The second complaint can be pain on chewing or biting or tenderness on percussion. This can happen in cases of symptomatic periapical periodontitis as well as acute apical abscess. Now, in the initial stages, when the apical abscess is not having enough swelling, how can we differentiate between these two findings? In cases of acute apical abscess, the pain happens on biting as well as it happens spontaneously. But in cases of symptomatic periapical periodontitis, the pain is only on chewing. It does not happen spontaneously. So, this is how we can differentiate between these two. Third, the patient can complain of swelling or spontaneous pain. Swelling and pain are most commonly indicative of acute apical abscess. Sometimes it is often accompanied by some systemic involvement. Lastly, the patient can have a bump or a draining sinus. If this information is given, it is very safe to mark chronic apical abscess. Now, these can be some tricky situations where there can be some scope of confusion, but how to distinguish between these two, let's talk about this. So, first is pain on biting. We have talked about this that the patient can have pain on chewing, and this can happen in symptomatic periapical periodontitis and acute apical abscess without swelling. How to differentiate between these two is in abscess, the pain is on chewing as well as spontaneous, but in symptomatic periapical periodontitis, it happens only on chewing. Second, if the patient complains of spontaneous pain, how to differentiate between irreversible pulpitis and acute periapical abscess without swelling? Both can present with spontaneous pain. In cases of acute apical abscess, the tooth will be non-vital. But in cases of irreversible pulpitis, the tooth will show some response, most commonly exaggerated. Third, the patient can just complain of swelling. Now, he cannot differentiate between acute and chronic abscess, but if he says that the swelling is happening again and again, it is evident of chronic abscess. And if the onset is uh, acute and it is accompanied by some systemic involvement and he's having severe pain, the intensity of pain, then it is very much pointing towards the acute apical abscess. Lastly, a yellow tooth does not always mean that the tooth is dead or the pulp is necrotic. Sometimes, in cases of calcific metamorphosis, also the tooth can turn yellow. But in that case, they will give you some findings and that will indicate the pulp is normal. So please don't get confused if you see a yellow tooth and you mark necrotic pulp. It is not safe to do so. And in the end, I would like to mention these conditions where it is safe to mark necrotic pulp in your diagnosis, even if no other information is given on the pulpal diagnosis. So let's see. If your periapical diagnosis is coming out to be one out of these three situations, first, asymptomatic periapical periodontitis, two, acute apical abscess, three, chronic apical abscess. Then, in these three situations, it is safe to mark necrotic pulp in your pulpal diagnosis because these conditions are always preceded by the pulp being necrotic. I hope this video has helped you to make an approach that will help you simplify things in your exam. So, I wish you all the best. Stay healthy.